Hello, I am Dr. Satish, specialist pediatrician working in eye care clinic under Emirates Group of Hospitals in OIC Center. Today's topic is asthma. Asthma is a chronic inflammatory disorder of the airway characterized by an obstruction of the airflow, which may be completely or partially reversed with or without specific therapy. Airway inflammation is the result of interaction between various cells, cellular elements and cytokines. In susceptible individuals, airway inflammation may cause recurrent or persistent bronchospasm, which causes symptoms that include wheezing, breathlessness, chest tightness and cough, particularly in the night during the early hours, and cough with exercise. Asthma is a clinical diagnosis. Child presenting with nocturnal cough or cough with activity, shortness of breath, audible wheeze along with atopic stigmata like eczema and allergic rhinitis, and family history of atopy can be diagnosed as a wheezer. All the wheezers are not asthma. It should be differentiated from post-inflammatory cough, episodic viral wheeze, croup or acute laryngotracheobronchitis, foreign body aspiration, tracheomalacia, pertussoid and endobronchial infections. Different phenotypes of asthma are transient early wheezer, non-atopic wheezer and IgA associated atopic wheezer. Babies born with intrauterine growth retardation, small for gestational age, with neonatal problems and history of ventilation or transient early wheezes. They may grow out of asthma, but anatomical defects should be ruled out in them. Non-atopic wheezes start wheezing associated with viral infection when they start attending school. IG associated atopic wheezes will have strong family history of asthma, eczema, allergic rhinitis and personal history of eczema. They come with episodic wheezing and may persist longer. Parents are often concerned about the feature of wheeze in their children. Asthma predictive index can be considered in predicting the chance of persisting asthma after 5 years of age. Parental asthma, physician diagnosed atopic dermatitis are major criteria, and physician diagnosed allergic rhinitis, wheezing apart from asthma, and eosinophil count more than 4% are minor criteria. If one major or two minor criteria are present in a child getting wheezing more than 3 episodes per year in the first 3 years of life, there is more than 90% of chance for persisting wheeze at 11 to 15 years of age. Asthma diagnosis can be supported by evidence of airway inflammation, fractional exhaled nitrous oxide, FeNO, more than 50 ppb more than 4 weeks in any lower respiratory tract infection predicts physician diagnosed asthma at 5 years of age. In pulmonary function test, forced expiratory volume in first second less than 60%, peak flow variability of 20%, bronchodilator reversibility greater than 12%, bronchial hyperreactivity with methacholine challenge test are evidence of asthma. Other supportive evidence like screen prick test to allergens, total IgE and specific IgE to allergens, blood eosinophil count, exercise challenge test can be employed when the response to therapy is not as expected. Asthma can be classified into intermittent, mild, moderate and severe persistent variety on the basis of daytime symptoms, nighttime awakenings, limitation of child's activity, need for reliever treatment and pulmonary functions. Atopic march in children start with eczema, food allergy and rhinitis, then finally into asthma. Atopic rhinitis and asthma are now considered as the same disease affecting the same airway. Common triggers in childhood asthma are allergens like cow's milk protein, egg protein, house dust mite, molds, tree pollen, cat, dog and horse, and irritants like smoke, dust, powder, perfumes and particle pollutions. As the problem in asthma are bronchial constriction and chronic inflammation, the bronchodilators like short-acting or long-acting beta agonists and steroids are the mainstay of treatment. Anti-allergics, leukotriene receptor antagonists like montelukast also play a role. The side effects are less when these medicines are given directly to the lungs in minimum dose. So inhalers are the best and time-tested modality of treatment for asthma. Stepwise treatment is adopted for asthma. 5 steps are there. Treatment start by trial with short-acting beta agonist like salbutamol. If there is any risk factor for exacerbation, start with low dose of inhaled corticosteroid. In the next step, add low dose inhaled steroid if salbutamol need is more than 2 times per month and night-time symptoms are persisting. You can try with leukotriene receptor antagonists like montelukast or theophylline as an alternative. In the next step 3, you can try low dose inhaled corticosteroid with leukotriene receptor antagonist or theophylline. You can swap leukotriene receptor antagonist with LABA in children above 5 years of age, or try moderate dose of inhaled corticosteroid. Continue treatment for at least 6 to 8 weeks before changing any drugs. 4th step is moderate dose of inhaled corticosteroid plus leukotriene receptor antagonist or theophylline and LABA in above 5 years of age. Tiotropium anti-muscarinic agent can be added. Instead of this, high dose inhaled corticosteroid is also an option. In the step 5, refer for add-on treatments like oral steroids, omalizumab, an anti-IgE monoclonal antibody above 6 years of age, subcutaneous bernalizumab, an anti-interleukin-5 monoclonal antibody which can be considered in eosinophilic asthma about 12 years of age, and rituximab can be tried above 18 years of age. Slit also is an option now. You can have single inhaler combination of steroid and long-acting beta agonist in children above 5 years of age for maintenance and rescue. Consider stepping down when the symptoms are under control for 3 months and no risk for exacerbation. Asthma control is assessed by asking whether the child had any daytime symptoms more than 2 per week, nighttime awakenings, daily activities limitation, a need for reliever therapy during the last 4 weeks. If the child has more than 3, it is uncontrolled asthma. If 1 or 2 only, it is partially controlled. If nothing, it is well controlled. Future risk of exacerbation, airway damage can be assessed by pulmonary function test at the start and after 2-3 months of treatment. Review response by observing disappearance of symptoms like nocturnal cough, exacerbations, reduced need for SABA, medicine side effects, patient satisfaction, and improved effort tolerance, return of normal lung function and return of normal PEFR with no variability. If response is not adequate, assess again for symptom control and risk factors, lung functions, inhaler technique and adherence, and patient preferences. Adjust treatment accordingly. Treat modifiable risk factors like smoking, obesity, and anxiety. Non-pharmacological strategies like exercise and aerosonate can be tried. Refer to specialist if the response to treatment is poor. Child with early onset symptoms, abnormal or atypical physical findings, abnormal pulmonary function test can be referred. There should be a personalized asthma action plan for every child. Maintain him on lowest dose of inhaled steroid. If any flare-up happens, double or quadruple the dose of inhalers and start oral prednisolone 1 to 2 milligram per day. If the child is not improving, bring him to the hospital for expert treatment. Always monitor the growth and the BMI. Every year, World Asthma Day is observed on first Tuesday of the month May. This year's theme is never too early, never too late. It is always right time to address airway diseases. So, educate the public that the asthma is treatable at any age. Thank you very much.